All right, so the last two lectures of the spine section are we're going to talk about the clinical pearls. And there's a lot of clinical applications and clinical scenarios for the spine that are pretty high yield for both anatomy exams, board exams, third year rotations. So we wanted to make sure we gave you the full spectrum, and not to make it too long, we kind of broke it up into two lectures. So this is the part one of spine clinical pearls. All right, so to start us off, we'll talk about lumbosacral strain. Now, that's really just a fancy word for lower muscular back pain. This is one of, if not the most common causes of low back pain, which, if you're not aware, low back pain is one of the most common causes in America for someone to see a doctor. So it's strain of these lower back muscles. Causes physical exertion, such as lifting heavy things, bending in improper posture, bending over to pick something up instead of lowering down to pick it up, overuse or trauma as well. Presentation, it's low back pain. It does not radiate at all, so this is not someone who's going to come in with sciatica-like presentation. It usually follows a pretty clear cause of incident. It's usually like, hey doc, I was lifting some boxes at my apartment. My low back's killing me. It's usually something like that. It's not like, oh, it just happened out of nowhere, or it's I was playing football and I hurt myself. I mean, it's usually something that's very, when you ask them what causes, they can usually pretty easily tell you what happened. On physical exam, this is a big thing to be aware of, and this is something you actually might see in a test question, is tenderness to palpation over the paraspinal muscles. So paraspinal meaning the muscles just lateral to the spinal cord. So in here and here. And so when the physician palpates or presses in this area and it reproduces the pain they have, that is what we mean by tenderness to palpation. That is a hallmark sign of lumbosacral strain or lower back muscle strain, okay? They're going to have a negative straight leg test because that's more of a test for disc herniation. And so this is not a disc herniation. It's just they strained or tore their lower back muscles, and that's what's causing their pain. And usually their neurological exam is normal. So they have normal reflexes, normal strength, normal sensation in the lower extremities. Treatments, what do? You do NSAIDs. You have early mobilization. So you don't want to tell these people to just lay on their back for a month. That's not going to do them any good. They got to just do activity as tolerated, keep themselves moving, give them exercises, even refer them for physical therapy. Disc herniations. Now, I know we talked about this earlier in their chapter, but just to review here. So this is an axial view of the intervertebral disc. Here's your nucleus pulposus, the annulus fibrosus, and if you remember, it's due to breakdown in the annulus fibrosus, as you can see here and here, and then the nucleus pulposus herniates out like this. So you can see this material herniating out. It compresses the nerve in the intervertebral foramen between two vertebrae. And because of it's the nature of the anatomy, and usually because the PLL is right here and is pretty tough, it kind of causes these herniations to displace posterior laterally rather than directly on the cord, and then that's as a result of that puts the nerves at increased risk of compression versus directly protruding onto the spinal cord. Cervical disc herniation, we'll start with that, and then we'll do the lumbar disc herniation. So how does a cervical disc herniation present? It presents with neck, shoulder, and or arm pain, okay? And then they often have weakness and numbness, and that's in the upper extremities is where that is. And often they'll have numbness in in their hand. Usually the common presentation is they have numbness or tingling sensation in their hands. Often it can radiate down their extremity from their neck. They can have weakness in their hands, and usually it can be weakness in the upper extremity, but it's usually weakness in the hands and fingers, especially like in an elderly person having trouble picking up pills in the morning, twisting doorknobs. It can be a very similar presentation to carpal tunnel, in fact, which is compression of the median nerve in this area here. So when you see these patients, what you want to roll out torticollis, which is a abnormal contracture of the sternocleidomastoid. You want to rule out shoulder pathology because shoulder pathology can lead to neck pain, shoulder pain, arm pain. It can cause weakness and numbness as well. As far as neurological disease, MS, you want to rule out carpal tunnel syndrome like we talked about. You want to rule out, Lou Gehrig's disease. Peripheral vascular disease can also have a similar presentation, and so that you want to check their brachial and radial pulses. Another thing, which is rare, maybe in a test question, you'd want to rule out like thoracic outlet syndrome as well. That's something that could cause it. We'll talk about thoracic outlet syndrome when we talk about the shoulder and that part of the upper extremity. So let's go through the hallmark physical exam signs. Now, in real life, you may not necessarily see this. It's fairly consistent. It's usually consistent, but it's not always in real life. But on an exam, this is what's going to be very clear, cut, and dry. Is, you know, if they have a disc herniation, and this is very high yield for your step 1 exam. You could see it on a shelf exam, step 2 exam. This is stuff that you should. It can very easily help you get the question right without having to spend too much time. So you got to know these roots. So C5 roots. So if you see one of these physical exam findings, the sensory finding, motor, or reflex, it indicates a lesion at C5. In the case of this, what we're talking about here would be a disc herniation that impinges on the spinal nerve, the C5 spinal nerve, okay? So let's go through the anatomy very briefly here again. So we have the spinal cord coming down here. If you remember, the cervical spinal nerves, they come down and they exit above the pedicle. So this would be our C4. And then you have the C5, which is going to come down here and exit here. So here's C5, C6, and so on. So we have a disc herniation, okay? It's going to bulge here. So we have it C4, C5, bulges into the C5 nerve. It's always the lower vertebrae of the vertebral level. And then it's going to lead to weak shoulder abduction on the motor sense. It's going to have weakness over here on the lateral shoulder. And then the reflex is the biceps reflex will be diminished or hypoactive. Okay? So those are the 3 markers of C5. C6, so again, let's draw our anatomy here. Spinal cord down. C6, so here we go. You're going to have the nerve come out here. It's right here. So you have a disc herniation, C5, C6. At this level, it bulges, hits the C6 nerve. The way you'll test, they could have numbness in other places on presentation, but when you actually test them clinically, the thumb is what's considered the indicator. So on the palmar side of the hand, on the thumb, that is what's indicated. If that's numb, that's an indicator of a lesion at C6. Motor is you would test if they have weak elbow flexion, and when I say weak, it doesn't have to be 0 out of 5. You know, even just 4 out of 5. You know, if you go by the scale of 5 out of 5. 5 out of 5 means full strength. 4 out of 5 means they can resist you, but not as strong as, maybe their normal healthy side. 3 out of 5 means they can resist gravity, so they can lift their arm off the ground. And 2 out of 5 means swinging lateral motion. They can't lift it against gravity, but they can still move it. 1 out of 5 is just some twitching, and then 0 out of 5 is they can't move at all. It's total paralysis. So like a spinal cord injury patient, who can't move their legs, that would be a 0 out of 5. That'd be an example of that. And then the reflex, just to finish this out, for C6 would be a hypoactive brachioradialis, which is done right in here. All right, and then here we have the C7 spinal root. So we draw our anatomy in here. Spinal cord comes down. This is going to be at the C6, C7 vertebral level. We have the spinal nerve of C7 come down like this. C7, disc bulge here at C6, C7, pushes on the C7 spinal nerve. Where you're going to, again, they could have numbness in a few different places. The C7 dermatome is not just located in the middle finger; it extends up. The C7 dermatome is this dermatome right here. It's the middle posterior or dorsal aspect of the upper extremity. But where you would test it clinically is in the middle finger, on the pad of the finger. If that's decreased sensation, and this is, you'll see this in test questions. They'll say, you test pinprick sensation on the thumb, that's C6, middle finger, that's C7, C8 would be the little finger. Weak elbows, and then as far as motor, you have weak elbow extension. Another thing is weak wrist, so it's twisted. Wrist flexion is another indicator, so weak wrist flexion. Also, weak finger extension, okay? So those are 2 more you can add to that. You can put that in, write that in the side on your book. So weak elbow extension, that's the main one. It's also weak wrist flexion. This is where it can get tricky. C6 is actually weak wrist extension, okay? So it's a little bit inconsistent. So, and then it comes back to extension again with the fingers. So back to C7 here. The hypoactive reflex would be the triceps reflex. All right, so we're going to wrap this up with discussion of the C7-T1 spinal level disc herniation, which affects the C8 spinal nerve. So let's draw the anatomy in here. So we draw the cord coming in like this, and then you have the C6 spinal nerve exiting above the C6 pedicle. Then you have the C7 spinal nerve exiting above the C7 pedicle. And then you have the switch where you have this C8 spinal nerve exits below the C7 pedicle. And that's what marks the transition between spinal nerves exiting above pedicles versus spinal nerves exiting below pedicles. And then that's what the pattern is for the rest of the spine. So for C8 and then into the thorax region, so T1 is going to go below the T1 pedicle. It's going to continue out the thoracic vertebrae and as well as the lumbar vertebrae. So the big level we're concerned with here is C7-T1, which affects the C8 spinal nerve. And if you look, it makes sense, just the way the anatomy works out. If you have a disc herniation here at this level, C7 is nowhere near this, so it's not going to affect it. T1 is coming out here below the T1 pedicle. So the C8 spinal nerve makes sense. It's the most vulnerable nerve to be affected by a herniation at this spinal level. So how do we clinically find it? So sensory-wise, it's going to be the ring and the small fingers. So it's going to be this region here and here, showing the palmar and dorsal aspects. So the way you test C8 specifically is you do pinprick on the tip of the small finger. And then as far as motor, the myotome, it's going to be weak finger flexion. So you're going to test finger grip. You're going to have them squeeze your fingers. And if they give you a very weak grip, that's going to be an indicator that's a C8 spinal nerve impingement. And then as far as the reflexes go, there's no abnormal reflexes associated with C8. So lumbar disc herniation presentation is low back pain, usually radiates to the buttocks and or the leg. And then you can also have weakness and numbness in the lower extremity. This is your classic sciatica, so here's the posterior view. It radiates down here to the knee, or it can even radiate down to all the way to the foot. And this is, your classic back pain of, radiating down the leg. Some special tests you can do to test for lumbar disc herniation is the straight leg test. And that's where you have the patient lay down on the examination table, and then you have them tell them to let you do all the work with lifting their leg, and so they keep their knee fully extended, and you pick their leg up by the heel of their foot, and you lift it straight up in the air keep maintaining that extension. And if that reproduces their pain radiating down the leg, that's what's considered a positive straight leg test. And it's not 100% sensitive, but it's a pretty good indicator of that they would have a disc herniation. They can have a disc herniation with a negative straight leg test. That can still be. But if you see this on an exam, this is a big indicator. The exams are more clear cut, or cut and dry as opposed to real life. It's a little more hazy with this physical exam stuff. But on an exam, very clear cut. Another thing is abnormal gait. So that's why you would have a spine patient just show them your gait, and then also walk on their heels and toes. And we'll talk about actually specific nerve roots that can be responsible for. The other thing is, you always have a differential in medicine. The thing you want to rule out is abdominal or pelvis pathology that can lead to low back pain that can mimic this. You can have pathology in the pelvis that presses on the sciatic nerve that's not a disc herniation, so you'd want to rule that out. You can have hip pain can often present with buttocks pain that radiates down the leg, so you want to rule out hip pathology. Knee pathology can also manifest this way with pain up in the hip and buttock region. You'd want to rule out, again, neurological disease such as MS, Lou Gehrig's disease, anything, spinal tumors as well, anything like that. And then peripheral vascular disease also can present with leg pain as well. And so a way you could test that just in a doctor's office is you test the posterior tibial and dorsalis pedis pulses. Posterior tibia is right here behind the medial malleolus, which is that bony prominence on the medial side of your ankle there. And then you can test the dorsalis pedis, which is where you palpate here on the dorsal surface of the foot. So let's get to the specific physical exam findings for the lumbar spinal nerve. So at the L2, L3 level, so that's this level here. Again, to review with the lumbar spinal nerves, we go down here. So cut. All right, now that we get to the specific exam findings for the lumbar spinal nerves, so here we have the L2, L3 level here. So let's talk about the L3 spinal nerve. The L3 spinal nerve is going to come down like this. And remember, spinal cord is ended about here, or even up here at T1, T12, L1. And so we're in the cauda equina here. This is the spinal nerves of the lumbar and sacral spinal nerves coming down. So we have the L3 nerve coming down, and then it drapes out like that. Remember, it kind of goes at an oblique angle just under the L3 pedicle, as opposed to in the cervical where it goes above the pedicle. So L3, then you remember, you know, like L4 would come out like this, L5 comes out like that, just below the pedicle at an oblique angle. So here, we're going to talk about L3 here. Okay, so L3, anterior and medial thigh. So this dermatome right here, this is where you'd find numbness, weak knee extension. Okay, and then there's no real abnormal reflex here as well. And then one thing I'll point out, we don't have it in that chart in your book, but one thing I just want to make a note of is L2. What you want to know about L2 is that L2 is weak hip flexion. Okay, so hip is L2. Knee is L3, ankle is L4, dorsiflexion, big toe is L5, and then plantar flexion is S1. Don't worry, we'll go through the rest of these. I just want to point that out. This is stuff that can pick you up exam points easy if you know these, okay? So let's get to L3, L4 spinal level. So that's going to be this level here. Again, let's draw our nerves. L2 is coming out like that. L3 is coming out like that. And then L4 is coming out like that. And then L5 is coming out like that. Okay, so let's talk about L4 here. L4 is going to be medial leg and the ankle. So this dermatome right here, that's going to be what's going to be numb. Okay. Now again, in real life, this is, you know, the whole leg could be numb, part of the leg. You know, it's not always going to follow the textbook in real life, but as far as the exam goes, this is what you want to be aware of. Is that what they'll usually do is they'll describe this. They'll be like, oh, on physical exam, the medial, just below the knee, the medial leg, and medial side of the leg and the ankle is numb. You know, on pinprick testing, you know, or the patient presents with numbness on the medial side of their lower leg. It's going to be something like that, and that's supposed to trigger you to know that it's the L4 dermatome area. Okay. As far as motor, is ankle dorsiflexion is going to be weak. The reflexes, they're going to have hypoactive patellar tendon reflex, so the knee tap reflex. Okay, that's going to be weak. Hypoactive, and just a little bit of neuroanatomy, they're hypoactive. This is, if you remember, if you've taken neuroanatomy, if you're taking it at the same time as this, upper motor neuron lesions, you're going to have hyperreflexia, lower motor neuron, which is more peripheral nervous system lesions. Since even though we're in the spine here, we're in the peripheral nervous system when we're talking about spinal nerves, okay, because we're outside of the spinal cord. So it's going to be a lower motor neuron sign is hypoactive reflex. So hyporeflexia is a lower motor neuron sign. Now, if you're just taking anatomy, don't even just put that out of your mind, okay? But I thought if you're taking neuroanatomy or if you've taken it before, this could maybe help you understand why it's hypoactive versus hyperactive, okay? Hyperactive reflexes would result if you had some kind of pathology pressing on the spinal cord itself, because that would be a upper motor neuron lesion, okay? Sorry for the digression there, but I just want to make that clear. Nothing abnormal on gait here. It's only two roots really that gives you a normal gait. We'll talk about that in a second. So then we'll move on to L5 here. So again, we'll draw the anatomy in. L2, L3, come down here, L4, and then we have come down here, and finally L5. Okay, L4, L5, spinal level disc herniation is going to be, you know, like this. The L4 spinal nerve is already exited, so it's our L5 that's still coming down in the cauda equina here. That's going to get compressed. The big indicator sensory-wise is this dermatome area here, dorsal foot and first web space. Motor, the big indicator here is, you know, they could have multiple motor problems, but the major one that's indicative of L5, and especially on an exam, is, like I said, it's the exams, it's going to be very clear-cut. So big toe dorsiflexion, so you have them lift their big toe up against, and then you press down on it and tell them to resist you, and if they can't do that, that's an indicator of L5. Spinal nerve compression. There's no abnormal reflex involved with L5. There's two gait problems, walking on the heels and foot drop. They can have one or the other, or they could potentially have both. Let's first talk about walking on your heels. So, walking on your heels. So, their dorsiflexion, when you have someone walk on their heels, they need to be dorsiflexed to do that, okay? So, they need to have their foot up like this, right? They need to be able to dorsiflex. So, if someone has an L5 spinal nerve, they're going to have weak dorsiflexion, okay? So they're not going to be able to do this. They probably won't be able to balance, or they might not even just be able to do it at all. And so that's going to be that could be an indicator for L5. Now, someone with L5 spinal nerve compression isn't necessarily going to present with inability to walk on their heels, but if they do, That's further supports your diagnosis of L5. Okay. Another one is foot drop. Okay. So again, they can't do this. They can't have dorsiflexion. So how they're going to walk? You have a foot like this, and their foot dangles like this. Okay. And so they're not able to do this, right? They can't do that. So their foot is going to hang. So when they go through walking, when they lift their, their foot, the affected leg up, their foot is going to still hang. They'll say, "Doc, it's weird. My foot hangs. I feel like I'm going to trip because it's just hanging down. I can't lift it up." So it makes it very difficult to walk. And it's a way they'll compensate is it's called a high steppage gait. Okay, you could see that sometimes in a question stem. So a high steppage gait is a way they'll compensate for that. Okay, that's a compensation mechanism for foot drop, and that's indicative of an L5. The other thing, a foot drop, there's two main things that can cause it. It's L5 spinal nerve, and then also there's a nerve in the lower extremity that we'll talk about in great detail called the common peroneal nerve, which is a nerve that wraps around your lateral, just below your knee, the lateral aspect. So it can be affected there. That can also cause foot drops, so that's another potential thing. So, but just to make you aware that we'll get much more in detail about that in the lower extremity lecture. But as far as disc herniations go, foot drop, L5, okay? Close this out with S1 here. So let's talk about, again, we have L3, L4, L5, and then we have S1 coming down here, okay? So that's the one here. Again, disc herniation here at the L5, S1. L5 is too high. It's already exited. It can't be affected by this disc bulge. It's going to go right into the S1 nerve here. What's the big indicator? So it's going to be the lateral and plantar foot. So we have the lateral dermatome here on the plantar surface as well. What's weak? Ankle plantar flexion. So stepping off. They have weakness in doing that. Reflexes, big time. So hypoactive reflex. So you take your reflex hammer and bang on their Achilles tendon here. That's going to be a weak reflex. As far as your gait goes, walking on their toes. So when someone walks on their toes, they need to be able to plantar flex, okay? So we'll draw this in here. They need to be able to do this, okay? They can't do this. So if they can't do this, they're not going to be able to walk on their toes, because when you have someone walk on their toes, that's what they're doing, is you're testing their availability to plantar flex. So that, again, that's another, not every patient with an S1 disc herniation is going to present with this, but if they do, especially on exam, this is a big indicator of S1. We're just trying to give you the clear-cut signs to help you get these questions right. All right, to close this out, we'll do the S2 to S4, spinal nerves compression. So that's in this area, the cauda equina. And again, this is typical. You'll see this in a cauda equina syndrome. Okay, and that's going to be, you'll probably see that in your book in a page or two. We'll talk about it in a couple slides. What we'll talk about here is the big things. So sensory deficit is perianal sensation, so that's going to be this dermatome here in the perineal area around the anal canal. The motor area is, and then the reflex involved here is anal squeeze. So the way you test that is you do a digital rectal exam, and if you don't feel a reflexive compression by the smooth muscle in the anal canal region, that is indicative of maybe possibly a lack of innervation due to an S2 to S4 spinal nerve compression. Now, the thing to note here is these don't innervate the lower extremities, so this is not going to be lower extremity signs. They innervate the pelvis, so bladder and bowel function. Another thing you can have is urinary and or bowel incontinence. That's another indicator. Incontinence. That would be another indicator of S2 to S4. So, and that's because of just the nature of the innervation. It's the pelvic organs they're affecting, not the lower extremities. All right, just to close this out, we'll talk about diagnosis and treatment. This is for any disc herniation, whether it's cervical, lumbar, doesn't matter. Major thing is MRI. Sure, often they'll have done an X-ray, CT scan. That gives you a good look at the bones, but the MRI is going to give you a good look at two things: the discs, and then the spinal cord and the spinal nerves. Okay, and this is a sagittal view of a lumbar spine. This is S1 right here. This is L5 here. This is L4 here. As you can see, these discs, they're nice and healthy. This is a T2 weighted MRI. T1, you see kind of fat more lights up. T2, it's more like fluid, water, or in this case CSF lights up. So you can see the spinal cord lights up. It lights up like a Christmas tree here. And then the fluid, this nucleus pulposus within the discs also lights up. So you can see that as well. If you did a brain MRI, you would see certain regions of the brain that have a lot of CSF light up as well. It's just the nature of the imaging technique. So if we look at this here, these discs, these look okay. There's not really any disc herniation. There's no real compression of the spinal nerves in here. But if you come down here, there's a big disc bulge here at L5-S1. As you can see, it's compressing in here, probably causing symptoms. This would be, so if this is the L5-S1 level, it's going to be S1 spinal nerve. They're going to have weak plantar flexion. Achilles tendon will decrease nerve sensation on the lateral and plantar surface of the foot, just to review all of that. As far as treatment options go, you do conservative and then you move more to invasive. So you do physical therapy, give them exercises to do. If that doesn't work, you can do corticosteroid injections, where you do epidural injections. Similar, it's just like how we're talking about the lumbar puncture earlier in the chapter. You put a needle. It's usually a pain management specialist puts a needle in here and injects some corticosteroid solution around here to help bring the inflammation down around the nerves. So that's another treatment option. And then lastly, you can do surgery. You can go in and remove these disc fragments, compressing the nerves. All right, so now spinal stenosis. Spinal stenosis, it's something on the boards they're going to really try to make you distinguish between spinal stenosis and lumbar disc herniations. Also, you can get cervical spinal stenosis as well. And again, distinguish it between that and cervical disc herniations. So, well, first let's talk about what spinal stenosis is. It's narrowing of the spinal canal and/or transforaminal foramina. So that would be these sections here and here. So where the spinal nerves are exiting out on either side. So it's both in the spinal canal here and in this transforaminal area here as well. So you have the spinal cord in here, traveling in the spinal canal. And what happens is, especially just in older people with age, another great thing with aging is you have degenerative disease of the bones and tissues in here. And what happens is it forms, bone spurs and other projections, and they compress on the cord, compress on the nerves, and that's what gives these symptoms. Okay. And since it's compression on all sides, the key way you distinguish spinal stenosis SS versus a disc herniation is disc herniation is usually unilateral. Now this is not, is usually unilateral symptoms, so it radiates down one leg, the pain's on one side, that kind of thing. Versus spinal stenosis is usually bilateral. Okay, so it radiates down both legs. The pain is on both sides. There's weakness in both legs. Versus unilateral, there's one leg that's affected. Okay, this is really the biggest way you can distinguish the two. Now if someone comes in and they have pain radiating down both legs, odds are it's more likely spinal stenosis than a disc herniation. Okay. Now, what causes spinal stenosis? It's usually due to degenerative joint disease, like we were talking about, resulting in these bone spurs that I've drawn in here. It could be ligament hypertrophy, so PLL hypertrophy, ligamentum flavum. Facet joint breakdown, so breakdown of these joints. That can cause arthritis and bone spurs and all that. Cyst formation, so you can have a cyst that forms around these joints and presses on the cord. Other causes, degenerative disc disease, so you could have a major disc. This would be a very significant disc bulge. This would be like the whole back of the disc blowing out. This would be really, really bad. This is not your run-of-the-mill disc herniation. This would be a huge, massive disc bulge coming out like this on the cord. Retropulsion of bone fragments during vertebral fractures. This is what eventually could lead to a spinal cord injury. Is someone has a vertebral body fracture, the part of the body projects posteriorly, affects the spinal cord, spinal nerves. Spondylolisthesis, which we'll talk about in a few slides here, that would be slippage of two vertebral bodies. So if we do like this on a lateral side, this would be spondylolisthesis is slipping of the lower vertebrae. Okay. Now, usually, I drew this anteriorly. You can also have spondylolisthesis posteriorly, and that's usually what would cause your spinal stenosis. That can cause spinal stenosis as well. Spine trauma, so just any kind of blunt trauma to the spine itself. Tumors, so instead of arthritic changes in here, you can have a tumor. You can have a tumor that's growing in here, either a bone tumor, some other kind of soft tissue tumor coming in here, a metastasis, and it keeps growing and growing and growing like this, and it keeps pressing on the cord, and that can cause a problem. Common example is that of prostate cancer metastasis to the spine can cause spinal stenosis, cord compression. So presentation, low back pain. It radiates bilaterally into the buttocks and lower extremities, like I was talking about. Now, this is a big difference here also with SS, spinal stenosis versus disc herniation, DH. Okay, it's worse with standing and extension. That's stenosis. Disc herniation is going to be worse with flexion. Okay, that's the big, and sitting. Okay, so that's a big difference here. You want to be aware of that. Spinal stenosis, the pain is worse with standing and extension, because the way you extend, that compresses the cord even more. It puts even more compression on. What extending the spine, what that does is it compresses the vertebral canal even more, and that's why someone with spinal stenosis has worse pain with standing and extension versus a disc herniation. When you flex, that causes the disc to push out more. It causes it to push out more posteriorly because of the way you're moving your spine, the way you're flexing it. The vertebral bodies are moving on each other. That causes the disc to protrude out posteriorly more. Okay, so that's the difference. That's why they have these specific presentations. These are very important to know, okay, for distinguishing spinal stenosis versus a disc herniation. Also, another thing, pain is better with flexion and leaning forward. So with spinal stenosis, flexion actually increases the amount of space available in the vertebral canal. Okay, so it frees up the cord a little bit. Okay, versus a disc herniation, someone flexes, it's going to be worse. Spinal stenosis makes it better. Big sign here, and you'll see this in test questions all the time, is someone leaning forward. So 2 examples, it's called a shopping cart sign, because someone says, when I lean on my shopping cart at the grocery store, I'm leaning forward. That makes it feel better, doc. That's a signature sign in a question about that it's spinal stenosis. Another example would be an elderly person who walks with a walker. They say, hey, doc, it feels better when I'm leaning forward. Okay? So that would be 2 examples. Again, since you're dealing with the nervous system, numbness, weakness as well. This is usually also bilaterally, okay? Neurogenic claudication. Now, this is a unique presentation of spinal stenosis. You will never see something like this with disc herniation. So what does this mean? You may have heard of intermittent claudication, okay? Now, intermittent claudication is a peripheral arterial disease presentation, okay? And that is, it's usually someone has pain when they're walking because they're not getting enough blood flow to their lower extremities, okay? It's usually just due to significant people with diabetes, smokers, people with significant peripheral vascular disease, okay? So what happens is in people with spinal stenosis is they have a very similar presentation, but it's not due to a vascular problem. It's due to the spine and having compression of both these spinal nerves bilaterally going into the legs in the lumbar spine. This is a lumbar spinal problem, okay? This is not a cervical spinal stenosis problem, okay? So they're unable to walk distances due to significant leg pain, okay? It's, like I said, similar to patients with vascular disease of the lower extremities. The difference is if you do Dopplers and you look at the arterial, their arteries are going to be fine. It's what the problem is it's the compression of the spinal nerves. It makes them weak. They can't walk as far, and they have a lot of pain. And so it's usually they can't walk as far. They need to rest, that kind of thing. Physical exam, like I said, bilateral numbness, weakness, hypoactive reflexes, abnormal gait, and or absent anal reflex. So this depends what levels you're at. If you have compression down more in that S2, S4 region, if you have spinal stenosis down more in that region, that can give you this presentation as well. How do you diagnose it? You have X-ray and CT, look at the bones. MRI looks at the discs, the spinal cord, the spinal nerves. MRI is what's going to really give you the best confirmation on diagnosis. How do you treat this? Physical therapy, corticosteroid injections, and or surgery, okay? Oftentimes, a lot of these patients doesn't have surgery because it's a structural problem. There's nothing you can do, as much physical therapy as you can. Problem is it's a structural problem. You can put as many injections in there as you want. It's just not, eventually for a lot of people, unfortunately, it doesn't do the trick. You got to actually physically fix it with surgery. All right, so that ends the first half of the clinical pearls for the spine. In Lecture 6, we're going to cover the second half of the clinical pearls for the spine.